Hello everyone. We have started the preparation for systemic surgery subject and we have already discussed the breast portion and the thyroid portion. Now we are coming towards the orthopedic surgery. So first of all we are having the AO classification. This is the association classification of the orthopedic trauma. This is internationally agreed classification of fracture using alphanumeric code. Numbers are used to detect the trauma or orthopedic trauma level. So the first number is the name of the bone. Then we are having the next letter which is A, B or C. The first number, for example, if it is 1, then it is the humerus bone. 2 is femur bone. Then second number is the shows the position of the bone. If the number is 1, then it is the proximal portion. If 2, diaphysis. If 3, then it is distal. The next letter that we are having is A, B and C. A is for which, B is for complex and C is for proximal and distant segment. So the other A, B and C are for extra-auricular, partial articular or complete articular segments. Okay, now coming towards what is the dislocation of shoulder joint. We are having a scenario that there is a 25-year-old male fallen over right shoulder in cricket. Examination shows obvious deformity of shoulder, arm in abduction and external rotation, and pulses are normal. What is the diagnosis? What is the management? And what are the complications? These are asked. So, head of humerus is driven forward and lies in front of glenoid. This is the diagnosis we are having. As it is described in the scenario that the 25-year-old male have fallen over his right shoulder in cricket. So, this is the head of the humerus is driven forward and lies in front of the glenoid. Now, what are the treatment options for this dislocation? Dislocation should reduce as early as possible. Methods to reduce are Coker's method, Hippocratic method, and hanging arm or gravitational method. So, in Coker's method, we are having traction. Traction is applied to arm while flexing the elbow at 90-degree, external rotation, adduction, adduct flexed elbow across the chest, rotation, rotate arm back internally until shoulder is reduced with definite clink. Okay, the second method is Hippocratic method. This is used when patient lies on bed. Traction is applied to with extended elbow. Traditionally, surgeon's heel is applied against side of the patient's chest to promote counter traction. The third method is hanging arm or gravitational method. The laying patient prone with sandbag under clavicle and hanging arm over edge of bed holding weight. The complications are axillary nerve palsy and recurrent dislocation. These are the treatment options for the dislocation of shoulder joint. Now coming towards the fracture of right humerus shaft. We are having a scenario that there is a patient 40 years old fracture of right humerus. Now classify the features and complications and treatment. So the classification of fracture is direct fracture, indirect fracture, complete fracture, incomplete, closed fracture, open fracture, and the other are according to the types. These are transverse fracture, green stick fracture, compression fracture, spinal fracture, butterfly fracture, pathological fractures, and communicated fractures. Now, what are the treatment options for the fractures of right humerus shaft? These are conservative treatment and surgical treatment. In conservative treatment, we are having U-slab with collar and cuff. Arm is bandaged to a slab of plaster running from top to acromion down to the lateral side of arm under elbow and up the medial side of arm for 5 cm. Rest the arm in a collar and cuff, give analgesics, maintain immobilization for 3 weeks. Hanging cast consists of plaster of Paris cast extended from axilla to the wrist. These are the conservative treatment. Now, what are the surgical treatments? We are having the indication when a satisfactory result is not achieved with the above conservative method. Now, open fracture is associated with vascular injury and multiple injuries and non-union. So, if these indications occur, then we will do the surgical procedure. For surgery, we are having the procedure open reduction and internal fixation using a plate, external fixation occasionally for associated severe soft tissue injuries, and non-union requires internal fixation and bone grafting. So what we have studied until now, first of all, we discussed the AO classification for the orthopedic trauma. Then we discuss a scenario for the dislocation of shoulder joint and the treatment options for it, which are Coker's method, Hippocratic method, and the hanging arm or gravitational method. Then we discuss what are the complications. Then we comes toward the fracture of right humerus shaft and we discuss a scenario which is 40-year-old fracture of right humerus. What are the classification of fractures and what are the complications? So this is the classification of fracture. It is broadly classified into four main classes, that is direct, indirect, complete, incomplete, closed and open, and according to the type. Then we discuss the treatment options, that for the fracture of humerus we are having conservative treatment and surgical treatment. In conservative treatment we will be doing use slab with collar and cuff and hanging cast, while in surgical methods the indications are when a satisfactory result is not achieved by conservative methods, and when open fracture is associated with vascular injury and multiple injuries, and when non-union occur. This is the procedure for the surgical approach of the patient when the conservative measures fails. Now coming towards our next topic, that is supracondylar fracture of humerus in children. We are having a scenario in which it is stated that 12 years old boy trauma fall on outstretched hands, unable to move his right elbow, painful and swollen and abnormal in appearance, pain on slightest movement, right forearm and hand is cold as compared to left, and right radial pulse is not palpable. So what is the diagnosis? How will you confirm the diagnosis? What is the management? What is the management of skeletal injury, and what is the management of ischemia in this patient? So first of all, the diagnosis is supracondylar fracture of the humerus in children. This is the most common fracture around elbow in children, and it is usually result from fall on outstretched hand. Whenever there is fall on outstretched hand, then it indicates that this is the supracondylar fracture of humerus. Now, first of all, we will do the investigations to confirm the diagnosis. For it, it is simple X-ray is done. Now, let's discuss what are the management options. We are having three different types of this fracture. For type 1 fractures are undisplaced. Type 2 fractures are angulated posterior but posterior remains intact. Type 3 fractures are completely displaced with overlapping of fragments. Okay, so what are the treatment options? Treatments is the type 1 fractures are undisplaced, so it should be treated conservatively. Type 2 are angulated posterior but posterior remains intact, so fractures are treated by close reduction and cast fixation with elbow at 90 degree. Type 3 fractures are completely displaced with overlapping of fragments, so the treatment is reduced under anesthesia by traction and manipulation, but open reduction may be needed if closed reduction failed or if there is vascular injury. Reduction is maintained by K wires. Okay, so type 1, type 2 and type 3, these are the three different features. Type 1 is fractures are displaced. Type 2 fractures angulated posteriorly but posterior periosteum remains intact, and the type 3 are fractures are completely dislodged with overlapping of fragments. Okay, now coming towards the management of ischemia in this patient. If ischemia occur in the supracondylar fractures of humerus in children, then how you will manage? First of all, immediate exploration, that is reconstruction of the brachial artery through autologous venous grafting or primary resection anastomosis, and post-operatively anticoagulants, for example heparin. Then complications occur. Complications are vascular injury, brachial artery, nerves, radial, ulnar and medial artery, and the malunion or non-union. These are usually the complications of all types of fractures. So what we have discussed in supracondylar fracture, first we studied the scenario. Then we do the investigations, and the investigation is simple X-ray. Then we classify the fracture. There are three main classification types. Then we will provide the treatment according to the fracture type. Then we discuss the management of ischemia in this patient, and then the complications. Okay, now coming towards the fractures of neck of femur. There is a scenario which states that there is a patient 60-year-old female under treatment of carcinoma breast develops sudden severe pain in right hip. Full down walking at home, fell down walking at home. X-ray pelvis showed multiple lytic lesions in upper femur with fracture of neck of femur. Fracture called diagnosis is asked, and what is the pathological intracapsular fracture? What are the primary tumors commonly spread by bloodstream to bone, and what is the management? These are the questions that are commonly asked. It is stated that there is a 60-year-old female which is under treatment of carcinoma, and she is having a history of fell down walking at home, and the X-ray shows pelvis, multiple lytic lesions in the upper femur with fracture of neck of femur. So the pathological intracapsular fracture called it is asked, and what are the primary tumors commonly spread by bloodstream, and what is the management option. Okay, we are having another scenario which states that a 72-year-old woman fall at home, severe pain in right groin, has been unable to get up since fall. On examination, right leg shorter than the left and is externally rotated, unable to actively lift her leg. Distal pulses and sensations are normal. So what is the diagnosis? What are the classification of these injuries, and what is the management? Intracapsular fracture of the neck of femur is the diagnosis. Okay. Pathological intracapsular fracture is the diagnosis in both these scenarios. What are the clinical features? Usually these are pain, tenderness, limb externally rotated and shortened. So injury to the lower back and left joint. Usually these are the diagnostic point from which we can identify a scenario, and there is a history of fracture in neck of femur. So this is the intracapsular fracture of neck of femur. What are the classification of these injuries? There is a kind of classification which is known as Garden classification. These are having different grades, 4 grades. Okay, so the first grade states that when there is incomplete fracture of neck, medial trabecular intact and vascularity reserved, this is the grade 1 fracture. When there is the complete fracture of neck reserved and without displacement, trabecular aligned and vascularity preserved, then this is the grade 2 fracture. When moderate displacement of less than half the diameter of femoral neck is present and trabecular and vascularity is disturbed, this is grade 3. The grade 4 is complete off-ended femoral head and is fully disrupted trabeculi and vessels. This is the grade 4 injury. Now what will be the management? It is intracapsular fracture. So for undisplaced and for displaced, we are having different kinds of treatment options. For undisplaced, it is treated by internal fixation with dynamic hip screw, and extracapsular is all cases require surgical fixation of the fracture by using sliding hip screw and plate. While if it is displaced, then in elderly osteoporotic patient is treated by replacement of compromised femoral head by artificial head, and in young patient, urgent reduction and internal fixation by using dynamic hip screw method is used. So what we have studied in the fracture of neck, first of all, we have read the scenario and the clinical features. In clinical features, we will be having pain, tenderness, limb externally rotated and shortened. And the injury to the lower back and left hip joint history will be present, and there will be fracture of neck of femur. So what is the classification of these injuries? These are Garden classification, and we are having 4 grades, that is 1, 2, 3 and 4. And the management, we are having different managements for undisplaced and displaced, which we have discussed. Now coming towards the femoral shaft fracture. In this, we are having a scenario that there is a 30 years old patient, fracture of right femoral shaft. So what is the treatment, what is the complication, and what is the classification? First of all, for the management in adults, we will do the traction. For fractured mid shaft femur can also be used in adult, but requires the patient to stay in bed for 12 to 16 weeks. External fixators will be applied to the lateral side of femur to stabilize fracture. Then internal fixation is done, performed with plating or intramedullary nail. Then intramedullary nailing is done, replacement of the blood loss is done, and the treatment of the associated injuries is provided. This is the general management for the femoral shaft fracture in adults. In children, treated with traction, gallows traction for infants and balance traction for children. What are the complications? Vascular injury can occur in femoral shaft fracture, nerve injury, non-union, malunion, knee stiffness and refracture. These are the common complications of the femoral shaft fracture. Classification is already done above, so you can study this. This is the classification of fracture. Okay. So what we have studied in the femoral shaft fracture, the management in adults and the management in children, and what are the complications. Now coming towards the tibial shaft fracture, bumper injuries. We are having the question or scenario that there is a 50-year-old patient having compound fracture of shaft of tibia What is the management? What are the complications and what are the treatment of complications? What are the common sites? The common sites are proximal 2 by 3 and distal 1 by 3. Okay, what are the management options? First, you have to follow the ATLS guidelines, then debride the wound, then analgesics, then antibiotics. Tetanus prophylaxis is done, and external fixation of the bone is done. For closed fracture and for open fracture. For closed fracture, non-operative method, for example, long leg, POP, cast, etc. For failure of non-operative treatment, require fixation with plates or nail. For open fracture, tibia is most common site of open fracture as most of part of tibia is lying subcutaneously. Skin closure is difficult and plastic surgical intervention is required to cover exposed bone by flaps, etc. What are the complications of tibial shaft fracture? These are vascular injury, delayed union, non-union, malunion, and foot drop. These are the common complications of the tibial shaft fracture. So what we have discussed the management options, then for closed fracture the non-operative methods, and for open fracture the methods and what are the complications. Now coming towards the osteomyelitis, what is osteomyelitis? It is bacterial infection of the bone which is acute and chronic. In acute osteomyelitis, disease of childhood often follows respiratory infection and skin infection. The clinical features are pain, pyrexia, tenderness, and systemic toxicity. What investigations will we do for osteomyelitis? We will do WBC count, that is CRP, and ESR, the X-rays, the isotope bone scan, the CT scan, the MRI, the blood culture, and the microbiology is done for the osteomyelitis. What are the management options? We will do first the resuscitation, then we will provide the antibiotics after culture and sensitivity, intravenous antibiotics for 2 weeks, and followed by 4 to 6 weeks of oral antibiotics. Splintage of the affected limbs is done. Radiology guided aspiration of the pus is done. Cortex of involved bone may be drilled at 2 or 3 sites to decompress underlying pus. Then for culture and sensitivity for appropriate antibiotic therapy is done. What are the complications? The recurrence, pathological fractures, chronic osteomyelitis, septic arthritis, damage to growth plate. These are the common complications of the osteomyelitis. Okay, what is a sequestrian microscopic dead of bone and new bone form around area of osteomyelitis in response to periosteal stimulation? Okay, so what we have discussed the osteomyelitis, that it is a bacterial infection. It is both in acute and chronic state. Then what is acute osteomyelitis and what are the clinical features? Clinical features are pain, pyrexia, and tenderness, and systemic toxicity. What investigations we will do? We will do the WBC, X-ray, isotope, CT scan, MRI, blood culture, and microbiology, and the management, the general management and specific management is provided, and these are the complications. Now coming towards the septic arthritis. What is septic arthritis? It is invasion of the joint with microorganisms. The scenario for septic arthritis is that there is short history of single hot, swollen, and painful joints. Joint is immobile on comfort, and passive movement gives pain. Knee joint is the common. What is the diagnosis and management? So what is the source of infection? Direct inoculation or penetration injury, local extension from nearby joint infection, and blood-borne distant metastasis organism. Staphylococcus and gonorrhea, H. influenza, group B, streptococcus, and pneumococcus. These are the source of infections. Now, what is the management and what is the investigation? For investigation, aspiration of intra-articular fluid for histology and culture sensitivity is done. For management, first treated as emergency, and medical management and surgical management is provided. Medically, antibiotics for 3 to 6 weeks, but after surgical intervention for first 2 weeks, antibiotics given intravenous. In surgical management, prompt surgical drainage is priority to some affected joint, open washout preferred, or arthroscopic washout. Now, what are the complications? What are the early complications and what are the late? In early complications, effusion, soft tissue swelling, muscle wasting, and periarticular osteoporosis. While in late complications, we are having secondary osteoarthritis, joint stiffness, fibrous or ankylosing spondylitis, destruction of the physis in children, and growth arrest abnormality. These are the complications of septic arthritis. So what we have studied the scenario, then what are the sources of infection, then the management and investigations. In management, it is treated as emergency, the medical management and surgical management is provided. What are the complications? We are having the early and late complications. Now coming towards the carpal tunnel syndrome. Carpal tunnel syndrome. So we are having a scenario that there is a 41-year-old hypothyroid lady, pain and tingling sensation in 3.5 digits of the right hand. So the compression and ischemia of median nerve in carpal tunnel is the diagnosis here. What are the causes of the carpal tunnel syndrome? These are idiopathic, diabetes, obesity, alcoholism, thyroid disease, pregnancy, inflammatory arthritis. What are the clinical features? These are tingling, numbness in radial 3.5 fingers, pain at night, relief by hanging hand. What are the investigation options that we will do? These are clinically wasting of the thenar muscles, Fallon's test, Tinel's test, and nerve conduction study is done for this purpose, that is wasting of the thenar muscles. What are the treatment options? Local steroid injections are given, conservative measures, for example, weight reduction, controlling diabetes mellitus. Physiotherapy is done, night splintage of the wrist in extension. In surgical decompression by releasing transverse carpal ligament is done. So what we have studied carpal tunnel syndrome scenario, that there is a hypothyroid lady of 41 years old and pain and tingling sensation in the 3.5 digits of the right hand. So what are the causes, clinical features, investigations, treatment and surgical options? Now coming towards the compartment syndrome, we are having clinical features that severe pain in legs, sensory disturbances, color changes and absence of pulse. There is a scenario which says that there is a 26-year-old motorcycle accident, sustained tibia and fibula fracture occurred that has been treated back initially by back slab in anticipation of centimeter operation tomorrow. Um, mm, he developed severe pain in spite of receiving enough intravascular analgesia. Patient discomfort, BP, and pulse are normal. So, what are the diagnostic points in this scenario? These are pain on the passive movement of muscles, swelling mostly after trauma or fracture. If these points are present, then the diagnosis is compartment syndrome. What is the definition of compartment syndrome? It is painful condition occur when pressure within muscle builds to dangerous levels due to increased pressure in compartment, which compress vessels, leading to ischemia by bleeding and swelling of tissues due to chronic or acute state. What are the differential diagnoses of compartment syndrome? These are DVT, edema, cellulitis, lymphedema, Becker cyst, rupture median nerve of head of gastrocnemia. Now, what are the acute cases and chronic? So, the acute are caused by severe injury without treatment, can lead to permanent muscle damage, and 5 P's are present, that is pain, pressure, paralysis, pulse, and paresthesia. The chronic phase is also known as external compartment syndrome, most often caused by athletic exertion. What are the management options for the compartment syndrome? These are bedside investigations, measuring compartment pressure, that is measured by using a catheter placed in muscles compartment and a pressure transducer. Compartment pressure is greater than 30 mm of Hg is an indication for urgent fasciotomy. Other investigations are CK level, urine RE, and uroglobulin. Late feature of compartment syndrome are numbness and paralysis. The treatment options are oil encircling bandages and plaster cast must be immediately split from top to bottom. Fasciotomy must be undertaken immediately if not relieved by splitting casts or bandages. Hydrate patient to prevent ARF due to myoglobinuria. What are the complications of compartment syndrome? These are premature nerve damage, premature muscle damage, tissue atrophy, tendinitis, department after RTA, and joint stiffness and myositis. So, what we have studied the compartment syndrome, its scenario, then the clinical features, then the diagnostic points, then the definition, then what are the DDs, what is the acute and chronic phase, what are the management options, what are the bedside investigations, measuring compartment pressure, other investigations, late features of the compartment syndrome, treatment and complications. So, here we have completed our orthopedic surgery unit. Let's revise it. First of all, in orthopedic surgery, we studied the AO classification, which is for the trauma classification in orthopedic surgery. Now, then we discussed the dislocation of shoulder joint, its scenario, then the treatment options. These are Cocker's method, Hippocratic method, and hanging arm or gravitational method. Then we have studied the complications. Then we discussed the classification of the fracture of humerus shaft. So these are direct, indirect, complete, incomplete, close, open, and according to the types, transverse fractures, green stick fracture, compression fracture, spinal fracture, butterfly fracture, pathological fractures, and communicated fractures. Then we discuss the treatment, that is conservative treatment, which is U-slab with collar and cuff, then hanging cast. Then we discuss the surgical methods. its indications and the procedure. Then we discuss the supracondylar fracture of the humerus in children, its scenario, then investigations to confirm the diagnosis, which is simple X-ray. Then we discuss the management, which is according to the types. These are three types of supracondylar fracture of humerus in children, and the treatment is providing to that. Then we discuss the management of ischemia in the patient and the complications. What are the fractures of neck of femur, the scenario. So for the fractures, you must know the classification, as one part of the question must come as classification. So then we discuss the fracture of neck of femur, then the scenario, then the classification of the injuries, which are 4 grades, then the management for both the undisplaced and displaced. Then we discuss the femoral shaft fracture, then its management in adults and children. Then we discuss a tibial shaft fracture, the management, the scenario, the closed fracture and open fracture, the operative and non-operative methods and the complications. Then we discuss the osteomolytic, which is the bacterial infection of bone, then the acute and chronic, the investigations done for it, the management options and the complications. Then we discuss the septic arthritis, its invasion of joint with microorganism. What are the sources of infections? What is the management option? What are the investigations? What are the medical and surgical options and the complications early and late? Then we discuss the carpal tunnel syndrome, the scenario, the causes, the clinical features and the investigations that are done, the treatment and the surgical options. Then in the last we discuss the compartment syndrome along with the scenario and the clinical features and the diagnostic points. Then the definition and the differential diagnosis of the compartment syndrome, then the acute and the chronic phase, and the management, which is bedside investigation, measuring the compartment pressure, other investigation, the late features of compartment syndrome, then the treatment options and the complications. In our next video, we will start the upper GID, which is a long unit and the most important unit in the surgery. We will discuss it in two videos, that is in 2 sections. Then the next unit after upper GID is lower GID, and in the end we will discuss the urology chapter. Thanks for watching.